The time may come when penicillin can be bought by anyone in the shops. Then there is the danger that the ignorant man may easily underdose himself and by exposing his microbes to non-lethal quantities of the drug make them resistant.
For so long, we have been blind to the miraculous medical impact of antibiotics. We have used them recklessly, with little consideration, but the fatal consequences have finally caught up with us. Fleming's prediction is now a reality. Every 45 seconds, a person dies from a resistant infection. Here in Africa, the situation could be worse than reported. This could be due to poor infection control measures, inadequate diagnostic facilities, increased exposure to substandard drugs, poor surveillance facilities, the high number of immune-suppressed people, and the socio-economic burden. This is just the beginning. A post-antibiotic era is setting in quickly. This could signal the end of modern medicine. Have you ever imagined dying from a small paper cut? Or a situation where a mother cannot undergo cesarean sections or emergency delivery surgery? This is what is coming. This is not all. Cancer treatment will no longer be effective. Small surgeries will be too risky to perform. And what's more, a small knee scratch will be a cause of alarm. It has already started. Many cases have been reported around the globe and it is slowly gaining track.
Then we will not be able to treat that patient. We will be able to lose very many patients. It will be a catastrophe, basically. It will be so bad that we might be wiped out as a generation or as humanity if we don't do something about it.
If we don't breach the tide, if we don't stop the tide of resistance, we're going to run out of affordable antibiotics.
Simple infections that we can treat will no longer be treatable with first-line drugs, and that will really result in higher rates of morbidity and mortality. In maternal and child health, Africa has been doing very well in that regard. But then now, if nothing is done now, we might actually be facing a situation where we are reversing all those gains now, where simple infections actually then affect the children.
We might be approaching the end of modern medicine. The discovery of antibiotics in 1928 changed the face of modern medicine. It became possible to treat simple infections, wounds, and cuts. Millions of lives have been saved, with the number of people dying from bacterial diseases decreasing dramatically. Antibiotics have also contributed to the successful deployment of other treatment strategies such as cancer treatment and surgeries. In surgeries, antibiotics are used as a preventive measure, protecting the possibility of surgical wound infections. In cancer treatment, antibiotics have been used to counter the incidence of infections as a result of immunosuppression caused by chemotherapeutic drugs. These are just basic examples. Antibiotics have had a huge impact on both human and animal health. We were quick to forget the miraculous transformation brought about by these antibiotics. We began to use them irrationally, and the ever-evolving bacteria outsmarted us. Antibiotic resistance can be described as a situation where bacteria develop mechanisms and change over time in a way that antibiotics are no longer effective against them. This can happen for antifungals, antivirals, and antiparasitics, but when these other drugs are involved, the term antimicrobial resistance is used. In the case of antibiotic resistance, when you have an infection caused by bacteria, the antibiotics will not be able to destroy the bacteria causing the infection. This means that your health situation will continue deteriorating, which could lead to a prolonged hospital stay, increased suffering, and death. In recent years, the situation has intensified in Kenya with various surveillance systems and a high proportion of resistant microbes and genes. What is the exact situation in Kenya, and what factors have contributed to the current situation? What could be done to avert this pandemic? We sought to hear from experts about the situation of AMR in Kenya and Africa at large. Our first visit was to the lady leading the fight against antimicrobial resistance in the country. Dr. Evelyn Wesangula is the national focal point of AMR in Kenya, a soft-spoken lady with a comprehensive understanding of the antimicrobial resistance situation in the country. She has been passionate about providing solutions for the antimicrobial resistance situation in the country from early in her career. She was at the forefront of developing the Kenya National Action Plan and the National Policy on AMR. She is already at the office when we arrive. It is 7:30 in the morning.
I think it's interest. One, I must say, when I completed my master's in tropical and infectious diseases, one of the things that I realized was that I needed to do more in terms of infection prevention and control. I actually had a very big interest in infection prevention and control. So when I was sent to a hospital in the western part of Kenya, I started spending a lot of time in the microbiology department. I would go look at the microbiology data. I would look at the antibiotic susceptibility data within the microbiology lab. I would look at prescription patterns in pharmacy because I'm a pharmacist. And I wanted to understand what the trends were. And I realized there were gaps. Some of the discs, antibiotic discs that were being used had actually expired like 6 months at the point of which I was looking at the data and trying to understand what's happening in the hospital. So that was my trigger for getting more interest and wanting to understand what are our prescription patterns, what are our resistance trends like, and I started working keenly on infection prevention and control and antimicrobial resistance at that point. Antimicrobial resistance is a growing public health challenge, not just locally but globally. The current status, as we have seen from studies that have been published, have actually indicated a rise in resistance trends across multiple microorganisms. That means many microorganisms are actually developing resistance against drugs or antimicrobial agents. And just to quote from a study that was published last year that looked at retrospective data in one of the referral hospitals here in Kenya, out of about 624 isolates that had been collected, 88% were actually multi-drug resistant. That means several antibiotics were actually not effective against these particular microorganisms. And about 24% of these isolates were actually extremely drug resistant. That means probably nothing was working.
We sought to find out why the AMR will affect Africa disproportionately.
AMR is a threat in Africa because Africa has weak health systems. And as you know, antibiotics are very important for managing most medical procedures and also the infections. And Africa is actually a continent that actually faces a lot of infectious, it's got a lot of prevalence of infectious diseases like malaria, TB, HIV, AIDS. And if you look at the drivers for antimicrobial resistance, like the misuse and overuse of antibiotics, you realize that that's a lot in Africa, mainly due to weak regulatory systems and also lack of awareness for AMR within the general public. So you realize that it's actually a very big threat, looking at the numbers that are actually going up, and the issue of diagnostics as well, which are a problem in Africa. where sometimes there's just indiscriminate use of antibiotics. See, someone is just given malaria antibiotics when they don't even need them because there are no tests that have been done due to the lack of access to effective diagnostics.
It is evident that the situation is dire in Kenya and Africa at large. As highlighted, antimicrobial resistance is majorly driven by poor behavioral tendencies, such as irrational use of antimicrobials in humans and animals. In Kenya and other African countries, there has been a constant dilemma between access and excess use of antibiotics. In remote areas of the country, patients have to travel several kilometers to access treatment. In addition to that, in urban areas, quality healthcare services are still inaccessible to people of lower socio-economic class, especially those living in urban informal settlements. Many healthcare facilities lack basic antibiotics. However, there are areas where antibiotics are easily accessible over the counter due to presence of many community pharmacies.
We have other challenges like enforcement of regulation, for example. We understand and we know that antibiotics are prescription-only medicines. So how is it that we can access them over the counter? That's an enforcement issue, and it's also an awareness issue for the public. So that's a loophole which I know with the review of the legislative and regulatory instruments, if that is done, then we can be able to seal that. The other challenge again is inadequate health professionals. We need health professionals that are well trained to be able to support the population, even in terms of proper prescription, proper dispensing practices, and even providing information to the general public. So if you don't have a well-trained workforce, that is also another area that can actually compromise the fight against antimicrobial resistance. And of course, the whole health system needs to be strengthened. Antimicrobial resistance is not a vertical issue. It's a health systems issue. If you touch one building block of the health system, you actually affect all the others. If you talk about financing, a lot of people don't go to hospitals because of the cost issue. So I would prefer to go to the pharmacy as opposed to go to the hospital because I think I have to do a lab test, which will cost me this amount of money. I will need to pay consultation fee. So the financing component also needs to be addressed. That's why I'm saying it's a health system issue. You have infrastructure, you have the health products and technologies. If the medicines are not available, even if the doctor has the right lab diagnosis, and in pharmacy that particular drug is not stocked, then it affects the whole process. That's what I'm saying. The whole health system needs to be strengthened for us to be able to effectively address antimicrobial resistance. So we see the weaknesses in the different building blocks of the health system, human resource. If these are addressed, then it gives us a better opportunity of addressing antimicrobial resistance. So all those areas have to be addressed.
As highlighted, it is a complex situation that is compounded by the availability of counterfeit medicine, management of pharmacies by unqualified personnel, poor storage, and irrational dispensing. Unfortunately, the Pharmacy and Poisons Board and the Kenya Veterinary Board are understaffed, and the current disciplinary actions are too lenient for the perpetrators. A large proportion of antibiotics are used in animals in the country. In agriculture, they have been misused greatly as growth promoters and for preventive use of diseases.
According to a situational analysis done by Professor Sam Karaoke in 2011, the current status of animal AMR in Kenya is that it is growing, especially amongst animals. Because in their research, you find that 36% of pigs or samples from pigs showed that there was multi-drug resistance. And the situation is similar across Africa, principally because there's been rampant use of antibiotics within the animal production system, especially around chickens, pigs, and dairy cattle.
The intensification of farming practices driven by an increase in demand for food due to the rising population seems to have contributed greatly to the misuse of antibiotics. More so, urbanization has led to reduced land for farming.
There is no justification whatsoever for increased use of antibiotics. In fact, in a recent poll that we did globally, that had 15,000 people responding to from 15 regions, because we have 15 regional offices, 1,000 people per office, we discovered that a lot of us do not appreciate the impact and the amount of antibiotics used in production systems. Yeah? Globally, it is now a known fact that 75% of antibiotics produced annually go into production system, into animal production system. That's a huge amount of antibiotics, about 131,000 tons of antibiotics going into production of your food, which then means that that is something that we need to look at critically. The justification has been that you have a growing population. It is estimated that currently we are about 7 billion, and in about by 2030, 2050, I think it was, we will be about 9 billion. We need to feed that population. We need to feed that population, realizing the fact that the land that we are growing food is also diminishing. In a recent survey we did in this country, in the neighboring country, one of the things that came out was that in that county, Kiambu, to be specific, farmers prefer to build houses or flats because it's cheaper. I have a flat instead of a chicken house. I have no overhead costs. It's a guy comes in, pays rent, and I'm good. The process of producing chickens is labor intensive. I have to be there every morning. I have to do all those things. So that's some of the things we need to be looking at. There's competition between urbanization and production systems. There is competition between the growing population with spaces. And that is why we are having situations like the pandemic we are talking about, COVID, where we are finding that COVID started in a place, a wet market in China, where we were eating wildlife. If you look at this country, and about 3 or 4 weeks ago, there was a big story which I think most of us missed, where we were talking about a certain avocado producing entity buying land in Amboseli, I think it was, and that land is part of the elephant pathways, which then means we are also pushing, the need to produce food is pushing us into natural habitats for wildlife, which is then becoming competition. And that is causing a lot of problems. That interaction between wildlife and ourselves are potential places where we can get other pandemics. But coming back to AMR, that is why we need to start asking ourselves, one, are we having enough spaces to grow the food that we need? Do we need to change our thought processes and start looking at alternative ways of production? Europe is now talking of things like clean meat, which is essentially artificially produced meat. Yeah? Europe is now talking of reducing the consumption of meat with plant-based proteins. Because anyway, for you to even get chicken on your table, the chicken must eat soya, which you can also eat directly so that we save that process. Those are some of the things some of the discussions that are beginning to happen. And that is part of the narrative that we need to start talking about, looking at as a country, because we need to start managing the food systems that we're in. We are a food insecure country. How do we then make ourselves food secure? I know we don't eat enough meat, but are there alternatives that we can be looking at? Those are all the discussions and the narratives that we need to be looking at.
Most of these problems seem to have been contributed by the low levels of awareness among the public. Surprisingly, this is the case among health professionals and students as well. This is associated with the technicality associated with this antimicrobial resistance and lack of simple ways to package this information in a way that is palatable to the general public.
Yeah, data and awareness is very low in Africa. If you look at AMR in itself, is a very technical issue, like just a technical, like packaging it to make it relatable to the general public is sometimes a challenge. Unlike some diseases, you know, when it's a disease, you can say cancer, HIV, so and so, it's a bit easier. But then when it comes to AMR, where we are saying it's not a disease, putting a face to it so that the general public understands is really a challenge. So you will notice that in Africa, of course, awareness and knowledge a bit high in technical circles. People know at least what AMR is and the relationship it has with animal, human health and all. But looking at the general public, awareness is very, very low. And then the economic challenges also further make the problem even worse. I think a lot of studies have been done where you actually see that sometimes people are not even aware that when they get antibiotics, completing the dose, a person will say, no, now that I feel better, I'd rather reserve this for the next time my child is sick, or they don't even know the effect of what they are doing because of lack of awareness.
It is something to be concerned about. Most students have insufficient knowledge when it comes to AMR and related topics, and even amongst medical students, we realize that they have moderate knowledge on it. So it is quite necessary to have the students well educated on matters regarding AMR.
And there's another problem. The antibiotic pipeline is running dry. The last time a new class of antibiotics was approved for clinical use was in 1987, 34 years ago. In August 2016, pharmaceutical giant AstraZeneca announced that it would be opting out of the drug research and development process. This came as a shocker to many, given the rising cases of antibiotic resistance. 2 months earlier, another pharmaceutical giant, Sanofi, had announced shedding of its anti-infective research and development unit. 1.5 years later, pharmaceutical giant Novartis announced that it would be terminating its antibacterial research at Novartis Institute for Biomedical Research at its campus in Maryville, California. Over 140 employees were laid off. This was a big blow to antibiotics research and discovery. When we thought it over, GlaxoSmithKline, another pharmaceutical giant, recently announced that it would be exiting antibiotic production. Drug discovery and development of antibiotics is no longer a lucrative business model. Research and development of a single antibiotic costs billions of dollars. There has been a reduced demand for antibiotics due to a decrease in infectious diseases in developed countries. Large pharmaceutical companies have shifted efforts to the development of medicines for lifelong diseases such as diabetes and hypertension. Infectious diseases are still a major health burden in Africa, Kenya included. These are the major contributors to death and disease burden. With such ongoing changes, what is the likely outcome of the healthcare situation in Africa? There is another dangerous trend. Injudicious use of antibiotics in animals undermines food safety. Several studies done in Kenya have had alarming outcomes. Antibiotics and resistant bacteria were found in food residues. Early this year, a research study by Wild Animal Protection collected samples from supermarkets in 6 counties across Kenya: Nairobi, Kisumu, Laikipia, Uasin Gishu, Nyeri, and Nakuru. The study aimed at identifying drug-resistant bacteria showed that out of the 127 pork samples collected, 98.4% had bacterial growth. In 206 chicken samples, 96.6% exhibited bacterial growth. The studies did point out a looming problem. With increased adoption of intensive farming systems in the country, the situation could be worse than reported. This partly stems from a lack of awareness among food producers. Many of them do not recognize the dangers of using antibiotics irrationally in farming systems. Antibiotics are categorized into several classes, mainly depending on their availability and effectiveness. First-line drugs are highly clinically effective, have fewer side effects, and are affordable. However, these drugs have been abused rampantly, and almost none of them can treat these resistant infections. This is being observed in many hospitals and is especially the case with urinary tract infection. This has and will continue to prompt the use of second-line and third-line drugs, which are unaffordable to many and have very severe side effects.
From my experience with dealing with AMR and AMS, there are some organisms that are definitely hard cause. There is what we call the escape pathogens, which are responsible for mostly nosocomial infections, and they tend to be most drug resistant. And these same organisms will definitely feature in the WHO priority list. The WHO priority list gives you the organisms that are really a big issue that we need to find solutions for. So some of these organisms, like I mentioned, the acronym ESCAPE, E is for E. coli, S for Staphylococcus aureus, K for Klebsiella, A for Acinetobacter baumannii, P for Pseudomonas aeruginosa, and then E for Enterobacteria. So you will find this also for appearing or featuring in either the critical or the high list of the priority list of WHO. So as a hospital, we are also not so different from this. So what we have experienced at KNH, the most common organisms that give us trouble will be Klebsiella, of course, Pseudomonas, and then Acinetobacter, and the Enterobacter, the E. coli, and the others. And these are organisms that will continue giving us issues unless we take measures to fight and to sort them. So the reason I would say that there's increase in resistance is, of course, antimicrobial resistance tends to be a natural process. Microbes will change over time and mostly mutate. And when you introduce subtherapeutic quantities of antimicrobials to these organisms, they tend to mutate to form different, through their genes to form different organisms, and then they pass this to their offspring, so to say. So the resistant, the ones that are susceptible are killed, and the ones that are resistant keep growing. So this is an issue that, of course, will continue being driven by the key drivers of antimicrobial resistance we mentioned earlier. And we all have a role to play to ensure that we are reducing this.
Just like COVID-19, drug-resistant microorganisms can spread from one person to another. The difference with COVID-19 is that the situation is more severe in antimicrobial resistance since it involves many infectious diseases. Additionally, there will not be new diseases where vaccinations and new medications could be explored. It will be too late. The untreatable diseases will have existed long with no antibiotic active against them. Such diseases are now emerging, with a common example being the There is a possibility that a larger number of deaths are not accounted for due to poor surveillance in Africa. The number of deaths is likely to affect African countries disproportionately. By 2050, 10 million people will be dying from drug-resistant infections annually, and this is set to increase even further. Almost half of this number, 4.5 million deaths, will be in Africa. The United Nations Ad Hoc Interagency Group has also warned that 24 million people will be pushed into poverty by 2030 if enough action is not taken.
Well, I do not want to throw in a hypothesis. I want to quote reputable organizations which say that if we do not sort our AMR situation now, within the next 5 years, we are looking at a pandemic, because we will have situations where we have disease-causing organisms that cannot be treated. Because the reality is that none of the drug firms is looking for new drugs. we have these antibiotics that we have today to manage them and ensure that we manage resistance and ensure that it lives beyond the next 5 to 10 years. If you don't do that, we are now saying 700,000 people are dying annually from multi-drug resistant or AMR resistant organisms. Yeah. If you don't do that, it is estimated by 2050 we'll be having 10 million people dying. That's a huge leap. Yeah. In maybe the next 20 years, something that we need to be wary of. The fact that there are no new drugs being looked at or developed to manage some of these processes, it simply means that if we do not manage this thing now, we will not have the capacity to manage it in another 5-10 years. Remember that one of the biggest, in an African context, one of the biggest cost of life is medical services. Yeah. Just imagine that we will have increased cost of medical services, which means a lot of us will not be able to afford it, just simply because we mismanage this process. But I think for me, the important thing is that if we don't manage it now, we will end up with a disrupted food system, because the food system will have animals that are disadvantaged, animals that have diseases that cannot be treated, animals that have challenges in their production system, and as I usually say, whatever you put in that animal production system is what the animal puts back to you. If you put an animal in a situation where it is being fed with food that does not meet its requirement, one, it will underproduce, but two, that food will not be wholesome. It means that you'll have a challenge with your food safety and food security, which then has an impact on your health and treatment and management of some of these things. So in a nutshell, we are tied to the animals that we have, and unless we look at that animal and manage it properly, we are looking at a situation where we will have challenges in the near future that we might not be able to manage.
We have global statistics and dim picture that if you don't take any intervention today, 5 years down the line, 10 years down the line, 50 down the line, there will be many repercussions, consequences, and impact, not only on the economy, but on health outcomes of the population. So to start with, from a patient level perspective, we are saying that we'll easily run out of options in terms of the treatment options that are available for treatment of infections. So we'll run out of options. We will not have a last resort the way we have some last resort for today. So it means when you get a patient will go to ICU and get serious infections or infected with super bugs, drug-resistant infections, then we will not be able to treat that patient. We will be able to lose very many patients. So increased morbidity from infections, bacterial, viral, fungal infections, increased morbidity, and more importantly, increased mortality. Increased days of hospitalization, people spending more days in hospital. Increased cost of healthcare. So healthcare costs will be increased. Increased healthcare associated infections. Sometimes people call them hospital associated infections. And the increased cost of treatment of hospital healthcare associated infections. So all that will have ultimately an impact on the economy, because people are getting sick, people are dying. The cost of healthcare is becoming very high, untenable. The government cannot be able to manage, and ultimately it will have an impact on the economy of the country. So for some people, they say it will be a catastrophe. It will be a catastrophe, basically. It will be so bad that we might be wiped out as a generation or as humanity if we don't do something about it.
We're going to run out of affordable antibiotics. We've had a number of antibiotics that are first line, and first line also tends to be the most affordable for the health system and for the patient, starting to show, resistance patterns, the conditions, the infections that were previously responding to these antibiotics. Now we're seeing a lot of cases of resistance. For example, ceftriaxone. it's really been the mainstay of managing a lot of infections. And so if we don't stem the tide of resistance by better stewardship practices, we're going to run out of affordable antibiotics and be forced to go into those reserve antibiotics that are harder to access, they are more expensive, and they are more hard-hitting on the body and can cause other problems.
For a long time, the scourge of antimicrobial resistance did not capture the attention of policymakers both at the national and the international level. However, there was a reverse of tides and an increased commitment to actions 6 years ago. In May 2015, the World Health Assembly endorsed a global action plan on antimicrobial resistance. All member states were urged to develop national actions on AMR by 2017. As per the call, Kenya launched its first 5-year national action plan and policy in 2017, and a national secretariat, NASIC, was established.
Yes, the Kenyan government developed the national action plan and the policy in 2017. And this was as a result of a global call for all countries to develop national action plans. Actually, at the global level, there was a global action plan that was developed by the WHO, the OIE, and the FAO, the Food and Agriculture Organization, and bringing together governments and putting together actions that needed to be done to combat antimicrobial resistance. And after doing 2 successive situation analyses at the country level, the next logical thing at a country level was to develop a policy and an action plan to address the gaps that had been identified in the situation analysis. So once we developed that in 2017, of course, the next thing is to implement policies that have been developed. It's now 3 years down the line. And I must say a lot has been achieved between 2017 and 2020. By the time we were developing the National Action Plan in 2017, we had not established a surveillance system for antimicrobial resistance, for example. But now we have an established surveillance system. We have a strategy for surveillance. We have an active national database for antimicrobial resistance. And the facilities that are actually on the surveillance system are already reporting data into the national AMR surveillance database. So I think this is a big achievement. We didn't have labs in 2017, but now we have 8. We actually have 13 human health labs and 6 animal health labs already on the national AMR surveillance system, which I think is a big achievement as a result of joint efforts between government and several partners like the CDC, the USAID, the Fleming Fund from the UK government, REACT, Africa, Infection Prevention Kenya, GAP. All these different stakeholders have contributed significantly to building the systems. We've also been able to put together a communication strategy for antimicrobial resistance, which wasn't there in 2017. And you're here because communication is a critical component. We've been able to carry out successive antimicrobial resistance awareness campaigns on an annual basis. This year, it's going to actually be our 7th campaign, and I think it's getting better. The involvement of different stakeholders, including students, I think is a big opportunity for us. So awareness is growing. Third, infection prevention and control efforts have also scaled up, and thanks to COVID-19, I think this was a big boost to the infection prevention and control arm, and we are seeing more people interested in taking up and implementing infection prevention and control guidelines. When we started in 2017, we did not have an antimicrobial stewardship guideline, but this year in July, we launched the National Guidelines for Antimicrobial Stewardship, focusing on appropriate use, not just within the healthcare settings, but even in the community, because use is not just limited in the community. We didn't have a lot of hospitals driving antimicrobial stewardship programs, but now we have hospitals that have actually instituted antimicrobial stewardship programs across the private and public sector. When we started off in 2017, we only had the national level with a governance structure like the National Antimicrobial Stewardship Interagency Committee. But as we speak, we have about 6 counties that have already launched their county antimicrobial stewardship interagency committees. So I think for us, we count those as gains. And we are not definitely where we were when we started off. We are doing much better, and we can do more. But I think what we've realized is that it's a huge task to implement an action plan or to implement a policy and the interventions that have been proposed in action plans. You need money, that's funding. You need human resources, which are scarce. You need infrastructure to be in place. So it's a heavy investment that needs to be done over time. So what we've been doing over the last 3 years is just to build the systems. Once your foundation is solid, then building on it becomes much easier. And also just making sure you have people speaking the same language, not just in human health. We also have colleagues in agriculture, in animal health. We have the environment that needs to come on board. So it's more of bringing multiple stakeholders together, reading from the same page and agreeing to move it towards the same direction.
The steps taken by the Kenyan government have been very promising. The National Steering Committee has been very active in implementing the plan amidst challenges such as low political commitment and low levels of awareness in the country. REACT Africa has been at the forefront, assisting countries to develop national action plans. We sought to understand the steps involved in the development of a national action plan and the steps in implementation.
I think in terms of an effective AMR National Action Plan, the Global Action Plan is a very good blueprint, provides a very good framework that has all the 5 focus areas where you look at awareness, surveillance, and also IPC and all. So these are good because they actually give a framework for stakeholders to work using the One Health approach as well. Because when you plan and you come together as different ministries, say for a country, you've done a situational analysis, you know where your gaps are. The National Action Plan then provides a framework for you to use in terms of AMR prevention and control. What are you going to focus on? And also it's good for the policymakers because they then have a document to work with, and also for evaluation of where we are and monitoring. It's actually a good thing. So an effective one is one that's actionable, one that is contextualized to the country, not just something on paper that when it comes to implementation, it's not going to work. And also one that, of course, AMR being a multi-sectoral problem, definitely needs a One Health approach. So a national action plan should cater for both human health, animal health, environment, for it to be effective. So if one does that, it also has action plan that really focuses on, and also the financial resources. You have to look at what budget are we having and how do we break it down for the years that we have.
We also sought to understand if there were other existing guidelines among stakeholders that guided the practice of healthcare workers and regulated the prescription and dispensing of antibiotics.
As a hospital, we are working on various guidelines and policies to support and to enhance our antimicrobial stewardship. So for one, we have a Kenyatta National Hospital Formulary, edition 2013, which is currently under review. So in this, we are, of course, considering what is happening and what is being done currently worldwide, and also guidance from our previous antimicrobial guidelines. We are able to include antimicrobials in the formulary that are needed. So that's one document that is very key that we are working on. And then we have also in progress our antimicrobial stewardship policy. So this policy outlines basically the goals and roles and responsibilities for various staff, the requirements that we need to have in place to ensure that our antimicrobial stewardship program is running well. And of course, with this, we hope that every staff will be aware of what is antimicrobial stewardship and what their responsibilities are in ensuring that we adhere to this. Then we have a surgical antimicrobial prophylaxis guidelines, which are also in development. All these documents are at an advanced stage, most of them just need to be approved for use. So the surgical antimicrobial prophylaxis guidelines will help standardize antimicrobial use in surgery, so that we have a coordinated way of ensuring that patients who need prophylaxis just get the right prophylaxis for the right duration of time. Then finally, we have our guide on empiric antimicrobial use in the hospital. So far, we have done 2 editions. The last one was in 2018. So that one is due for review towards the end of this year. So we need to review that guide as well. Now, through other sponsors, for example, we have Fleming Fund, which is helping us to develop a clinician handbook. So the clinician handbook covers more on diagnostic stewardship, which is a key aspect to ensure that antimicrobial stewardship is working, and then we are able to reduce AMR. So these guidelines are also in development, and what we hope to see with all this is that all staff and all healthcare workers in the hospital will know their role, and they'll know what they're expected to do, and they'll work in a synergistic way to ensure that we are doing antimicrobial stewardship in an organized way in the hospital, and by this we'll be able to reduce antimicrobial resistance. So we are very hopeful that this will go a long way.
Despite the various guidelines instituted, the situation in Kenya is still dire. Our research revealed that it was very easy to purchase antibiotics over the counter in community pharmacies across different parts of the country. With the increased transition of healthcare financing from out-of-pocket to insurance coverage among the middle class, many healthcare workers are under pressure to prescribe unnecessary antibiotics for the optimization of profits, especially in private hospitals. This is a growing trend, and the government should initiate action to curb such practices. Additionally, urbanization has led to an ecological imbalance. Poor waste disposal systems, congestion, and poor housing in urban informal settlements contribute to the surge in resistant microbes, especially in the soil. Due to their playful nature, children are thus highly exposed to contracting drug-resistant infections.
As for the urban informal settlements, we realize that the residents in these areas lack proper knowledge on antibiotics usage and have poor hygiene and sanitation practices. Therefore, the rates of infection in these areas are quite prevalent. And with insufficient knowledge, they tend to use antibiotics to treat trivial infections, which will also increase the problem of AMR. So by educating these people on the proper hygiene practices as well as proper antibiotics use, we will eventually reduce the problem of AMR.
We have seen little government commitment in the fight against AMR. How then can we make policymakers understand that AMR is so important and requires immediate investment?
For us to make a case for investment, we must have data. We must be able to cost AMR. What's the impact of AMR, the economic impact of AMR to the country? We must be able to carry out studies that can be able to make an economic case or be able to estimate the economic impact of antimicrobial resistance. When we have that information, this is the one we can go with it to stakeholders or policymakers and tell them this is the impact. If you don't do something now, this is what's going to happen in 5 or 10 years to come. So it is important that we invest. And it is only at the time when Kenya will start investing, putting in money for combat of AMR. It's only at that point that we'll be able now to start seeing results. Because currently we are not making any investment as a country. All the investments we are making is actually mostly from donor funding. A lot of the programs that we are running in the country for AMR are donor funded. So we need to start having funding that is coming from the government, from Ministry of Health, and from all the other stakeholders to be able to deliberately fund programs that are targeted towards combat of AMR.
A lot needs to be done in terms of raising awareness of the dangers of antimicrobial resistance among the general public. It is no longer a futuristic threat, but a ravaging pandemic. This requires collaborative efforts among all stakeholders, including media outlets. It is also in our capacity to ensure that we take individual responsibility and educate those close to us. In the meantime, you can help reduce the spread of this pandemic by adhering to the following guidelines. Do not buy antibiotics over the counter. Always finish your dose as instructed by the healthcare professional, even when you think your health situation has improved. Do not share antibiotics with your family and friends. Do not flush antibiotics in the sink. For our farmers, do not use antibiotics to promote the growth of animals or in prevention against diseases. Instead, adopt good farming practices, such as adequate spacing for the animals and regular cleaning to prevent the spread of these infections. Do not drink or sell milk immediately after livestock are administered antibiotics. Always observe the withdrawal time highlighted by the healthcare professionals. And finally, raising awareness on antimicrobial resistance. George Santayana, a famous philosopher, once said, "Those who do not learn from history are doomed to repeat it." COVID-19 manifested the disruptive impact that a disease can have on all aspects of life. Antimicrobial resistance consequences are far much worse. Let us conserve the existing antibiotics, lest we give way to the end of modern medicine.